presenter. Assalamu alaikum. All the residents are here, or still some eating cakes outside? So today we'll discuss retinal vasculitis. It's a very important topic, and I noticed years ago that there was a lot of confusion regarding the terminology of retinal vasculitis, when to call it vasculitis, vasculopathy, and also, for example, if you have a patient with Irvine gas syndrome, patient with macular edema, complicated cataract surgery, if you do fluorescein angiography, what do you expect to see? You see a lot of leakage. Will you call this vasculitis? No. So we have to be very specific about vasculitis and differential diagnosis of vasculitis. For example, if you have also a patient with severe retinal ischemia, patient with diabetic retinopathy or central retinal vein occlusion with a lot of capillary non-perfusion, if you do fluorescein angiography, what do you see also? You see a lot of leakage, which is due to the ischemic. Do you call this vasculitis? No. So we have to be specific about the term of retinal vasculitis so that we can do the proper differential diagnosis and workup. That's why my aim in this lecture is to keep you familiar with the topic. As I said, when I started years ago here at King Abdulaziz University Hospital, there was no clear definition of retinal vasculitis. I was personally very much confused. And that's why I started to read, I started to attend the meetings, and then gradually we had some sort of a clear view about retinal vasculitis, and this we translated this clear view into this review article, which is called The Clinical Approach to Diagnosis of Retinal Vasculitis, which is used nowadays very frequently as an important reference for retinal vasculitis. In this article, in fact, to give you an idea how it was confusing, that one of our colleagues, Dr. Manfred Zroth, he is now the editor-in-chief of Ocular Major Inflammation, he organized one-day workup, international workup, to discuss retinal vasculitis, definition, approach, differential diagnosis, and so on. So with the help of my colleagues, Dr. Karl Herbert and Professor Tabbara, we thought that writing a review article on how would you approach the diagnosis of retinal vasculitis based on the clinical presentation, based on the clinical findings in the patient. So as an introduction, retinal vasculitis is a vision-threatening inflammatory disease that involves retinal vessels. We have the advantage in the retina that we can see clinically retinal vasculitis. We don't need biopsy to diagnose retinal vasculitis. مش كده؟ We see it clinically with indirect ophthalmoscopy, direct ophthalmoscopy, slit lamp biomicroscopy, and helped with fluorescein angiography. So it can occur as a complication of infection, so we have to rule out infection. It can occur as a complication of tumors, neoplasms. I'm going to show you examples. It can occur in association with systemic inflammatory disease, and it can be an isolated idiopathic condition. If you look at the bacterial disorders in our region, the most common is tuberculosis, that you have to rule out. If you look at viral, we have human T-cell lymphoma virus type 1, cytomegalovirus, herpes simplex virus, varicella zoster virus, and others. Parasitic toxoplasmosis. Rickettsial disorders, this is described frequently by our colleague Dr. Monsef Khairallah from Tunisia, Mediterranean spotted fever, Rocky Mountain spotted fever. If we look at neurologic disorders, multiple sclerosis is a common cause of retinal vasculitis. We recently, with the help of Dr. Belushi, we submitted an important article on clinical findings in UV associated with multiple sclerosis, and retinal vasculitis was the most common clinical finding. I'm going to show examples for MS, retinal vasculitis, and to show you that it is typical and you cannot miss it with for other vasculitic entities. The other neurologic disease is called Sussex syndrome, which is a microangiopathy of the brain cochlea. The importance of this syndrome is that you should be able to diagnose it clinically because it can be messed with multiple sclerosis. If you diagnose it properly, then you will save the life of the patient. Malignancy that can masquerade as vasculitis. We have paraneoplastic syndromes, ocular lymphoma, and acute leukemia. If we look at systemic inflammatory disease, a big list. Most common is Behçet sarcoidosis and other systemic vasculitic entities, most common systemic lupus erythematosus. There are ocular disorders only limited to the eye after you do all the workup and everything is negative, so this is idiopathic. So as I said earlier, that the retinal vasculature is accessible to direct visualization using ophthalmoscopy. You don't need biopsy to diagnose it. So the diagnosis is made clinically with the help of fundus fluorescein angiography. And I'm going to show what are the fundus fluorescein angiographic findings in retinal vasculitis. Clinically, the active vascular disease or active vasculitis characterized by exudates. When you have inflamed blood vessels, there is exudates. Exudate formed of inflammatory cells and the edema. So there is exudate around the retinal blood vessels, and this exudate will result in what's called white sheathing or cuffing of the affected vessels. We have to differentiate this sheathing or cuffing from sclerosed white vessels. Frequently in end-stage disease, you will see sclerosed white vessels. Frequently in branch vein occlusion, as a chronic one, you see sclerosed white vessels. This is not vasculitis. It's just sclerosed white vessels. Is that clear? I'm talking about active vasculitis, active sheathing or cuffing of the involved blood vessels. This is the classic example. So when you see this picture, you can see the blood vessel is surrounded with active sheathing. These are inflammatory deposits, inflammatory cells. It is perivasculitis. It is not, most of the histopathological studies show that there is perivascular inflammatory infiltrate. It is not in the wall of the blood, but it is perivascular. So you can see here the active vascular sheathing, and they frequently associated with hemorrhages because of the disruption of the blood retinal barrier that will allow also blood to come in the retina. So is this picture clear for you? So this is the classic picture that you should see in a patient with active retinal vasculitis. If you look at pathological data, as I said, the most accurate term is perivasculitis because the inflammation is not, in most of the cases, is not within the blood vessel itself, in the wall of the blood vessel. It is in the perivascular space. So there is vascular sheathing composed of inflammatory exudates in the perivascular region. And most of the cases, the inflammation is involving the veins. So if you look here, you'll see that the veins are mainly affected. So it is most of the cases called periphlebitis. Now we have histopathology studies to support what I just said. We have good histopathological studies related to multiple sclerosis, retinal vasculitis. The histopathological studies in multiple sclerosis showed segmental perivenous inflammatory infiltrate composed of lymphocytes and the plasma cells involving retinal veins corresponding to the clinical finding of sheathing. Is that correct? Clear? Examples. This is a patient. I remember this patient was, she was a university student. She came here, she presented with what do you see in the cornea? Matum fat cratic precipitates. Multiple sclerosis is a granulomatous disease, okay? And then what do you see here? The vascular sheathing. The vascular sheathing, as we wrote in the manuscript, is still under revision, of multiple sclerosis is very characteristic for multiple sclerosis. If you see this picture, do MRI, most of these cases, they have demyelinating lesions. And the vascular leakage on fluorescein angiography in MS is typically focal. It is never diffuse, as you see in Behçet disease or in tuberculosis. So it is mainly a focal vascular sheathing. So again, look at this. This is typical for MS. Another patient, pseudocyanicia, matum fat KPs. Is this type of vascular sheathing similar to the previous one? All of them the same. It's elongated vascular sheathing that looks as if the blood vessel is fibrosed. This type of vascular sheathing, you see it only in multiple sclerosis. Another patient, bottom fat KPs, see granuloma, center segment inflammation. Look at the vascular sheathing. It's exactly the same. Another case, bottom fat KPs, pseudocyanicia, and the vascular sheathing in the periphery with focal leakage. And MRI will show the leakage. Another patient, so the vascular sheathing is classic and very typical from MS. I remember years ago during morphine uveitis course, there was a presentation about, do we need to do MRI for patients with uveitis? I told them, you don't need. There's only one occasion when you see this type of vascular sheathing. This is for us is an absolute indication to order MRI for the brain, and that we wrote this in our paper that because when we analyzed the data, we looked at all our patients with uveitis that we ordered for them MRI, and what were our criteria to do MRI, and in how many of these the MRI showed positive findings for multiple sclerosis. So if we look at sarcoidosis, again, the histopathology in sarcoidosis showed epithelioid cell nodules around the retinal blood vessels, which are corresponding to the clinical appearance of perivascular exudates with an appearance like candle wax dripping. So this is an example of vascular sheathing in a patient with sarcoidosis. This is another patient with sarcoidosis. What do you see here? One bottom fat KB. And we always said that even one bottom fat KB is enough to make a diagnosis of granulomatous disease. Right? Only one is enough. And then look at the pseudo segment, optic disc swelling. Optic disc is swelling in the left eye. But here, what do you see here? You see candle wax dripping. Perivenous sheathing. And fluorescein showed inflamed optic nerve. Right? Nothing more. But what happened when you did ICG? What do you see? You see a lot of dark spots, granulomas, which were not visible in fluorescein angiography. That's why when we suspect sarcoidosis, by the way, a patient with uveitis with bilateral optic nerve head swelling and inflammation always think about sarcoidosis. And the ICG helped us to diagnose, and even the other eye, the left eye, is more severely involved with multiple granulomas. Behçet disease is another retinal vasculitic entity in which histopathology is available, and the histopathology showed lymphocytic infiltration of the retinal blood vessels. An example, this is a patient with Behçet disease. Look at the vascular sheathing, but the patient had also inflammatory branch vein occlusion. The infratemporal branch is involved, has a lot of hemorrhages, and look at the vascular sheathing. Here the leakage is different from that of MS. It's diffuse leakage. And here there is delayed filling of the infratemporal vein, confirming the presence of infratemporal inflammatory branch retinal vein occlusion. And as I shall discuss later, presence of an inflammatory vein occlusion is highly suggestive for Behçet disease. And this is a picture that was given to us by Professor Enomata on the histopathology of the retina of a patient with Behçet retinal vasculitis. Then you can see the very heavy inflammatory infiltrate around the retinal blood vessel. We have also histopathology for barciplanitis, in Berde-Schott chorioretinopathy, just to tell us that the sheathing is composed of inflammatory cells. Inflammatory oxidate. What you see as a sheathing is inflammatory oxidate. Now, the situation in patients with systemic vasculitis, such as systemic lupus erythematosus, Wagner's granulomatosis, bullous arteritis nodosa, Church-Strauss syndrome, is different. That's why we call it vasculopathy. So what happened in this condition? It is not true vasculitis. It is retinal arterioles or branch retinal arteries occlusion by macrothrombosis. If you have retinal arterioles occluded by macrothrombosis, what do you expect to see clinically in the eye? Infarctions. Because if the veins are occluded, you expect to see hemorrhages and edema. If the arteries are occluded, you expect to see infarction. So what we see in this patient with systemic lupus erythematosus and other systemic vasculitis is multiple infarctions. So there is occlusion by macrothrombosis. So this is not a true vasculitis. It's just, but the people sometimes they mix vasculitis with what we see in SLE as occlusion by macrothrombosis. So we prefer to call this vasculopathy. So this will cause cotton wool spots representing macroinfections of the retina. Therefore, this type of occlusive vasculopathy should be recognized and distinguished from other conditions characterized by true vasculitis. So this is what we expect to see in a patient with SLE, multiple cotton wool spots due to macrothrombosis occlusion of the retinal arterioles. So when you see this picture in a young woman, always think about systemic lupus erythematosus. Only one differential diagnosis, which is systemic lupus erythematosus. And this is another example of a patient that had ciliaretinal artery occlusion causing ischemic whitening in a patient with SLE. There are animal models for retinal vasculitis. The monkey model that was produced by Professor Fuk Luang, Rabbina Yashfi, he described in monkeys the development of retinal vasculitis after immunizing them with retinal S antigen. This is the pictures from, he was so kind to give me these pictures from his research. Then you can see in the monkey immunized with retinal S antigen, you see the same picture as you see in humans. Retinal vascular sheathing and vascular leakage. And then here you see vascular leakage in this animal model. And there is also, and the histopathology is showing also very vascular inflammatory infiltrate. And we have also a rat model for patients with retinal vasculitis. So what are the clinical findings in a patient with vasculitis in general? The patient can be symptomatic or asymptomatic depending on where the inflammation is in the eye. If it is in the periphery, it might be asymptomatic. If it is in the center, the patient will come with symptoms early. There is decreased vision, floaters, and visual field scotomas. But the main clinical finding is sheathing or coughing of the blood vessels. Macular edema is common in these patients. Occlusive vasculitis affecting the retinal arterioles, as I said, will cause cotton wool spots representing macroinfection of the retina. Occlusive vasculitis involving the veins, which is called periphlebitis, will cause retinal edema, intraretinal hemorrhages, and hemorrhagic infarction of the retina. In patients with ischemic retinal vasculitis, and retinal vasculitis can be very ischemic and destructive to the retinal circulation, leading to new vascularization, proliferation of fibrovascular proliferation, repeated retinal hemorrhages, vitreous hemorrhage, and detraction retinal detachment. So this is again to remind you, this is what we call it active vascular sheathing. Fluorescein angiography is essential in the workup of these patients, in the imaging. If you do fluorescein angiography, you will expect to see leakage of dye due to breakdown of the inner blood retinal barrier and the staining of the blood vessel wall. Leakage may be focal. Again, fluorescein angiography is very important for the differential diagnosis because if the leakage is focal, you have to think about sarcoidosis or multiple sclerosis, as I showed you. If it is diffuse, you can think about Behçet disease or tuberculous vasculitis. If you have diffuse capillary leakage, most of you who rotated with us, we showed them many of these cases during the infliximab clinic. If you have diffuse capillary leakage, think about Behçet disease and Berdeshot. Unfortunately, Berdeshot coretinopathy is not present in our region, but it is common in Europe. And fluorescein angiography will show you that the extent of vasculitis is more extensive than what you could see clinically. And this is an example of diffuse leakage in a patient with tuberculous retinal vasculitis. Fluorescein also useful to diagnose macular edema, but nowadays OCT is more important. It can show you optic disc inflammation. it can, in patient with occlusive vasculitis, it will delineate the area of capillary non-perfusion. It helps you to diagnose neovascularization, second to retinal ischemia. And it can also help you to diagnose inflammatory branch retinal vein occlusion in patients with Behçet disease. Examples. This is a patient who, one of the recent patients that we admitted to our department. In fact, I saw him yesterday in the follow-up. Right eye, we operated, we did vitrectomy because he had vitreous hemorrhage complicating occlusive retinal vasculitis. And this is his left eye. And then you can see the active vascular sheathing. You see fluorescein angiography, which is showing capillary non-perfusion, and the optic nerve is inflamed. This is an example of a tuberculous retinal vasculitis where you see peripheral retinal ischemia and leakage from the new vessels. So these patients, they need laser treatment. In addition, of course, to medical treatment, you need to fill the ischemic retina with a scatter laser foot coagulation. OCT nowadays is very important to diagnose macular edema and also to monitor the efficacy of treatment, because this patient can lose vision because of chronic macular edema. So this is another patient with occlusive retinal vasculitis, again was admitted recently, and then you can see the extensive ischemia. And with angio-OCT, this is the superficial plexus, and this is the deep capillary plexus. It also allowed us, which was using non-invasive angio-OCT to show the ischemia. Now, when you examine a patient with retinal vasculitis, you have to look if it is affecting veins or arteries. Because if it's affecting veins, you can think about Behçet disease, tuberculosis, sarcoidosis, multiple sclerosis, barzillanitis, and HIV infection. If it is affecting the arteries, you can think about acute retinal necrosis, IRVAN, we shall discuss this later, and systemic vasculitic entities, such as systemic lupus erythematosus. If you see cotton wool spots, again, you are seeing a patient with retinal vasculitis. I'm going to discuss how would you approach the diagnosis based on the signs present in the retina. So, presence of many cotton wool spots, which represent microinfarctions of the retina due to precapillary arteriolar occlusion. You can think about systemic vasculitic entities. That's what I call it vasculopathy, such as systemic lupus erythematosus. Or the other conditions that can, at presentation, show many cotton wool spots, Sussex syndrome. So if you see many cotton wool spots at presentation, think about two conditions, either Sussex syndrome, microangiopathy of the brain, retina, and cochlea, and systemic vasculitic entities such as systemic lupus erythematosus. Because both of them, the arterioles are occluded. Examples. Systemic lupus erythematosus, this is the same picture that I showed you. And this is a patient that was referred from another city in the kingdom. The lady was referred with the diagnosis of retinitis. Do you agree this is, do you think this is retinitis? What do you see? Many infarctions. Some of them are very large, like here. But this is mainly infarctions. So if you see such infarctions, you have to think about occlusion of retinal arterioles. And what can cause occlusion, bilateral, extensive occlusion in the retinal arteriole like this? SLE is common. She was a 22-year-old woman. Then we did fluorescein. Then you can see that there is, in fact, extensive occlusion of the retinal arterioles. We referred the patient. We made the diagnosis in our hospital. The patient showed she was both anti-nuclear antibody, high titers, anti-double-strand DNA, C-reactive protein, and low complement 3 and 4. Then we referred to rheumatology. I still remember Dr. Sultan al-Migarin. He treated her, but unfortunately, she had only 20 to 100 vision. And you can expect this because of the severe macular ischemia in both eyes. Another patient with systemic lupus erythematosus with occlusion of the retinal arterioles here called infarction of the retina. How about Sussex syndrome? Sussex syndrome is a microangiopathy of the brain, retina, and cochlea. It is a small vessel vasculitis causing microinfarctions of retina, brain, and cochlea. So there is a triad of encephalopathy, branch retinal artery occlusion, sensorineural hearing loss. The fluorescein angiography is typical. I'm going to show you examples. This is a patient who was referred to us from neurology. And what we could see that the patient has multiple contour spots. Is that clear? The patient, in fact, was admitted at neurology department with a possible diagnosis of MS. I'll tell you why. So when we did fluorescein angiography, what you see here, you see large segments, retinal arterioles occluded. Clear? And then the occluded arterioles, the proximal part, is showing leakage. In fact, this type of leakage is pathognomonic for Sussex syndrome. If you look at all articles on Sussex syndrome, this is a classic leakage you see in patients with Sussex syndrome. And this is, I called the neurologist and I told him, most likely your patient had Sussex syndrome. And he said, what? I never heard about this, this disease. Then I told him, okay, look at the literature. And then the problem with diagnosed Sussex syndrome is that the MRI findings in Sussex syndrome can be very similar to that of multiple sclerosis. So that is, this is another patient. In fact, the one who did the diagnosis in the emergency room was our colleague who finished, Dr. Ghazai. He called me during Friday and he said that I think I'm seeing a patient with Sussex syndrome. So the patient, she's a young lady, she presented with cotton wool spots here, and if you do fluorescein angiography, there is occlusion of the arterioles in the macula, in the fovea, and also the typical leakage from the involved arterioles. And this is the other eye, and you see many cotton wool spots. And look here, you see the occluded arterioles and the classic leakage. And we did angio-OCT that showed more or less the same finding as fluorescein angiography of occluded capillaries in the fovea. So the brain biopsy in this patient showed microinfarctions, perivascular inflammatory infiltrate of the small vessels, MRI of the brain lesion suggestive of multiple sclerosis. Why it is important to make the diagnosis? Because you can save the life of the patient by immunosuppressive therapy, including corticosteroids or cyclophosphamide. Now, during the evaluation of a patient with vasculitis, the patient, so we covered now the type of vein, the vessels, either veins or arteries, to limit your differential diagnosis, and if the patient had contour spots. Some patients with vasculitis, they can present also with intraretinal infiltrates. So seeing intraretinal infiltrates, it can indicate either an infectious process, you have to rule out an infectious process, and if you rule out infection process, then you are left with one diagnosis, which is Behçet disease. So intraretinal infiltrate, white, they call it sometimes chalky white retinitis. White intraretinal infiltrates are pathognomonic for Behçet, active Behçet disease, and it can be the first manifestation of these are transient white patches of retinitis with adjacent intraretinal hemorrhages, and this is a sign of activity. So this patient can have hypopion, but if you look here, you can see this white patches with intraretinal hemorrhages are pathognomonic for Behçet uveitis. It can mimic sometimes viral etiology, but because we are seeing this disease on a daily basis in the emergency room and in the clinic, so we are perhaps having more experience in diagnosing this disease compared to our colleagues in Western countries. And the fluorescein angiography will show diffuse leakage involving the capillaries. There's another example of whitish infiltrates, frequently misdiagnosed as viral retinitis. And here you can see the leakage involving capillaries. Here again another patient with Behçet disease and the diffuse leakage, and here is pathognomonic. Another patient with retinitis, diffuse leakage, and this patient had the retinitis in the fovea, so that for us is an emergency. This disease, as discussed before, we treat this patient initially with anti-tumor necrosis factor alpha agents. It's an indication now to use it as a primary treatment. And the diffuse leakage involving capillaries. Now you can have vasculitis with necrotizing retinitis. The most common is ocular toxoplasmosis. The second most common is acute retinal necrosis. And then we see it, we don't see a lot of cytomegalovirus retinitis in our clinic. But toxoplasmosis is a focal necrotizing retinitis, which can be close to an old scar, as you can see here, and associated with vascular sheathing. I have one patient in the ward now. She's pregnant with a focal necrotizing retinitis, but she's unfortunate because it is involving the optic nerve and macula. So this is another patient, another disease, and necrotizing retinitis, and old scar, and vascular sheathing. Another patient, necrotizing retinitis, but look here, fluid angiography is showing that the blood vessel which is crossing the lesion is occluded, and the optic nerve is inflamed. Another patient, in patient with toxo, the anterior segment examination can be inflammation can be granulomatous, as you can see here, and the toxo-retinitis. Cytomegalovirus can be a manifestation of AIDS, or in a patient who are immunosuppressed for other reasons. Can be, the retinitis can be associated. Retinitis here is different. There is no vitritis mixed with blood, and it can be associated with vasculitis. This is frosted branchiangiitis in a patient with AIDS. And this picture was given to me by Professor Nick Jones from England. This is extensive vasculitis, what looks like frosted branchiangiitis in a renal transplant patient with BCR-proven gan-cyclovir-resistant cytomegalovirus infection. Acute retinal necrosis caused by herpes group of viruses. It's a disease of immunocompetent individual, but it can happen in immunocompromised individuals. It's one of the emergencies in uveitis. And the patients can have vasculitis in the arterioles and the peripheral necrotizing retinitis, which is confluent. You can see here, this is a vasculitis involving the arterioles. And if you do fluorescein angiography, it's occlusive vasculitis. This is another case, peripheral necrotizing retinitis confluent and vasculitis involving the retinal arterioles. So it is an example of vasculitis involving the arterioles. So you can see the vasculitis involving the arterioles and the peripheral necrotizing retinitis. This is a very aggressive disease. Peripheral necrotizing retinitis is very confluent. And if you do fluorescein angiography, there is shutdown of the retinal circulation. This patient, despite extensive treatment, she developed retinal detachment, which is a common complication of this disease, and she was operated with silicone oil tamponade. Another vasculitic entity, not common, but you have to know about it, which is called IRVAN. IRVAN is aneurysmal dilations of retinal and optic nerve head arterioles. So just to make it easier for you, IRVAN, if you see a patient with IRVAN one time, you'll never miss it. Along the arterioles, you see aneurysmal dilations. That's what call it aneurysmal IRVAN. So you see the aneurysmal dilations along the arterioles. And then there is always large patches of hard exudates around the optic nerve and involving the macula. And sheathing involving the retinal arterioles. If you do angiography, can you appreciate the aneurysmal dilations? Is that clear? And then the optic nerve head is always inflamed. And then in lit frames, you see leakage from the aneurysmal dilations. Other eye, same patient. A lot of hard exudates, sheathing involving the retinal arterioles, so it is involving the retinal arterioles and inflamed optic nerve. And the aneurysmal dilation can be within the optic nerve, but what's typically here is the aneurysmal dilations. So if you know about it, you will never miss the case. And another feature of IRVAN that can lead to visual loss is peripheral retinal ischemia. That's why you have to look at the periphery, and the patient will need scatter laser photocoagulation in the retinal periphery. And this is the same patient. After we give him laser treatment, we give him a trial of systemic corticosteroids. So you see, we published this case because the treatment led to regression of the aneurysmal dilation, and most of the hard exudates cleared. But because of the extensive nature of the hard exudates, they always leave a scar. But the patient had good vision, 20 in one eye and 20/30 in the other eye. And you can see here the aneurysmal dilations regressed. There's another patient that was, she is an ophthalmologist. She was seen in Moorfield Eye Hospital, and they did not make the diagnosis of IRVAN. But when she came to us, we could see the hard exudates. We see peripheral ischemia. This is the other eye. It's a classic picture, like the previous patient. And she had hard exudates involving the center of the macula. And you see the peripheral ischemia. And you see some aneurysmal dilation and leakage from these aneurysmal dilations. And the other eye, can you see the aneurysmal dilations? Is that clear? So IRVAN, if you see aneurysmal dilations, think about IRVAN. Now, frosted branchiangiitis. Frosted branchiangiitis is just, this is a clinical terminology. It means a heavy perivenous exudates that resembles the frosted tree branches. Like here, this is what's called it the frosted tree branches. In one meeting, I was in Switzerland, in the mountain, and that I put this picture because who described this as frosted branchiangiitis? He was using the appearance that you see in the with frosted tree branches, and this is what we call it, frosted branchiangiitis. Then you see the heavy perivenous exudate involving the veins. So frosted tree branches or frosted branchiangiitis is not a diagnosis. It's just a clinical terminology. And there are so many diseases that can cause this picture. And like it is described in SLE, Crohn's disease, toxoplasmosis, human T-cell lymphoma virus type 1 infection, AIDS with a small patch of retinitis, HIV without retinitis. So before you make a diagnosis of idiopathic frosted branchiangiitis, you have to rule out all these conditions. It can also be seen in patients, I'm going to show you example, in patients with lymphoma or leukemia. So ischemia, retinal ischemia is an important issue in patients with retinal vasculitis because many of these entities can lead to occlusive retinal vasculitis. And then you have to be very careful in looking at, it's better to have wide angle fluorescein angiography, because if you identify ischemia, if you apply scatter laser to the ischemic retina, then you will save the patient blindness. Because in the presence of ischemia, there will be always neovascularization, fibrovascular proliferation, recurrent vitreous hemorrhage, and detraction retinal detachment. The most common cause of retinal ischemia is tuberculosis, which is occlusive retinal periphilippitis. It is the most destructive to the retina. This is, of course, we rely on strong positive tuberculin skin test. And if you see a patient, we published this with Dr. Salman Al-Kharashi years ago in the British Journal of Ophthalmology, how should we manage a patient with tuberculous retinal vasculitis. If the patient had active disease, you need anti-tuberculous therapy with systemic corticosteroids. If the retina is ischemic, you need to do laser photocoagulation. If the patients bleed, you need to do early vitrectomy. The earlier the vitrectomy, the better the outcome. So this is a patient with tuberculous vasculitis with diffuse vascular leakage. This is another patient. I remember the patient was misdiagnosed in the emergency room as branch vein occlusion. But this is inflammatory branch vein occlusion, because you see here vascular sheathing. And this is a patient with tuberculous vasculitis, and look at fluorescein angiography, severe retinal ischemia. Another patient, already pre-retinal hemorrhage because of new vessels on the optic nerve, extensive sheathing, a lot of hemorrhages, and ischemia. Another patient presenting with pre-retinal hemorrhage. And this is a patient with peripheral ischemia, neovascularization. If you do fluorescein large area of retinal ischemia. And this is the pattern of lasers that you need to apply. You need to apply a scatter laser photocoagulation only to the ischemic retina. There's another patient, a young male with tuberculous retinal vasculitis, a lot of hemorrhages, neovascularization, ischemia, fluorescein angiography, macular edema. Then you'll see the outcome. Combination of medical treatment, steroids, and tuberculosis treatment, and scatter laser treatment. Then you have now a quiet eye, and patient, no macular edema. We managed to keep his 20/20 vision. Then these patients, they can present with traction retina detachment, so they need vitrectomy to flatten the retina. The severe ischemia can cause also rubeous iris, as in this patient. Patient disease can cause ischemic retinal ischemia, but much less common than tuberculosis. But inflammatory retinal vein occlusion. I was giving this lecture in Italy, and I was asked by a medical retina specialist, and she asked me, when do you call it inflammatory vein occlusion? I told her, very simple. If the vein occlusion is associated with vascular sheathing, this is automatically inflammatory vein occlusion. Look here, this patient with Behçet, you see vascular sheathing? This cannot be a normal vein occlusion. This is inflammatory because you see here vascular sheathing. And the patient had inferior temporal branch retinal vein occlusion. Look, do you agree that this is inflammatory? Do you see the vascular sheathing? So, and fluorescein angiography will show delayed filling of the infratemporal vein compared to the supratemporal vein, and also ischemia. And this is another example, as I showed you before, of inflammatory branch vein occlusion because of the vascular sheathing. And this is another example of inflammatory vein occlusion. What do you see here? Collaterals. So this is, all these cases had Behçet disease. Another condition here, another patient with inflammatory vein occlusion. And this was a dramatic presentation. A young male, 22-year-old male, and he presented with a picture suggestive of central retinal vein occlusion. But what do you see here? Huh? You see, there's vascular sheathing. So the patient had Behçet disease. We gave him infliximab, and the patient ended with 20/20 vision. Now, just everyone in this room should know that malignancy can masquerade as retinal vasculitis. This is a patient who had acute lymphoblastic leukemia. Then you can, do you think this picture is similar to that of frost branchitis? Huh? It's very similar. But here, the sheathing is caused by malignant cells. So the patient has acute lymphoblastic leukemia. So always you have to rule out malignancy when you see such picture. So the diagnostic evaluation of this patient, it is a multidisciplinary approach. You need to consult rheumatologist. You need to consult also infectious disease specialists and other disciplinary. But what is most important, that you need to distinguish between infection versus non-infection. Because if in an infectious disease, like acute retinal necrosis, and we have seen these disasters, or toxo, if you give the patient immunosuppressive only without coverage with antimicrobial agents, you will lose the eye. If it is non-infectious autoimmune disease, then you need only immunosuppressive therapy. If it is infectious like tuberculosis, you need to combine the steroids with anti-TB treatment. And you should rule out malignancy. And the diagnosis is based on a differential diagnosis, as I said, derived from history, review of systems, physical examination. That means that the workup should be tailored for the disease you are dealing with. I am seeing bad examples of patients coming to the clinic, and I'm seeing the residents ordering unnecessary investigations, like anti-nuclear antibody, anti-DNA, rheumatoid factor, toxicology. The workup should be tailored for the particular disease. You cannot order all these investigations unnecessarily. Complications, cystoid macular edema is common in this patient, but the good thing is that Zystoid macular edema responds very nicely to treatment. And the patient regain vision if they are presenting early. Macular ischemia, it's an important cause of visual loss, but you cannot reverse macular ischemia. Peripheral capillary closure ischemia with peripheral capillary closure is common in tuberculosis. Peripheral ischemia, as I said, can lead to proliferative vascular retinopathy, fibrovascular proliferation, vitreous hemorrhage and detraction, retinal detachment, rubiosis iridis, neovascular glaucoma, and functional loss of the eye. Inflammatory vein occlusion, this is usually associated with Behçet disease. Retinal arterial occlusion causing infarctions. The most important differential diagnosis would be systemic lupus erythematosus. So in conclusion, retinal vasculitis is not only vision-threatening disease, but could be the first sign of a potentially lethal systemic disease. You need prompt diagnosis and institution of appropriate therapy that will help to control the ocular disease and systemic disease. That means that you need to have good history, review of systems, physical examination, and to make the diagnosis. Multidisciplinary team approach is essential in evaluation treatment. Diagnostic evaluation should be focused, guided by history of ophthalmic and physical examination. Meaning that if you make a diagnosis that the patient has Behçet, do you need to order anti-nuclear antibody, anti-DNA? Do you need to order toxicology? Do you need to order rheumatoid factor? No. You need to order only basic workup to clear the patient for immunosuppressive therapy. BBD skin test, because if the patient has strongly positive BBD, you cannot give infliximab, for example, unless you give prophylactic anti-B treatment. Otherwise, you will induce miliary tuberculosis. Thank you very much for your attention. We can have like 1 or 2 questions. It's not PRP, scatter. Because you don't do PRP like diabetes. For example, if you want to ablate the anterior retina, it's called the scatter laser. In one sector, scatter laser. This is a good question because I was asked by same question before in other meeting. We control the inflammation for a few days by systemic immunosuppressive therapy. And then we can add the laser. So we do at the same time, during the admission. Dr. Marwan كان عنده مريض, remember you had one patient admitted with occlusive vasculitis, yes, recently, and we did the laser during admission. Because if you discharge the patient with severe ischemia, you're not sure the patient can come in time to follow up. We prefer to give full laser because it is vision saving.
Yeah. New. Second, middle. Yeah.
This one. This is it?
Go to the next one. This one.
That's it. This is the laser one fuse.
And up and down is.
This one next previous. Okay, sir.
Thank you. Then it's a big exercise of changing the
it's
all
too much?
fonts. Yeah.
How many slides? Okay, so
So Next time we will put something that first slide will be the template slide and then we
Okay.
can do it.
طيب, that's great, yeah. People will never see unless we... Assalamu alaikum. Good afternoon, ladies and gentlemen. It's our pleasure to announce the speaker of the Grand Round, the research department. I think everybody is familiar with Dr. Rajiv. Dr. Rajiv is working as a chief of epidemiologist and research department in KKESH since 2012. He had a very long CV and contribution to the hospital, to prevention of blindness. Needless to mention that he was of great support to the residents and fellows during their thesis, and he's still active in doing that. He's going to speak today about the epidemiological inputs in ophthalmic research, and it's going to be divided in two sections, the epidemiological part and then the biostatistical part. So please join me in welcoming Dr. Rajiv. Yeah, go ahead.
Good afternoon, everybody. Every year we have lecture series of research department, especially targeting for new fellows and residents coming in academic year. This time we decided that let them settle in their new environment and then have the exposure to research, because that is part and mandatory for their activity when they are in KKESH. As Dr. Samar has said, I will try to cover the topic of my presentation into two parts. First is epidemiology in ophthalmic research, and the second is basics of biostatistics, which a researcher should know when they want to do medical research. The knowledge of epidemiology, it will be helpful to you because it helps you in gathering the evidence-based information from the large ocean of knowledge which now we are exposed to in this cyber space. A number of journals of your subspecialty as well as of general ophthalmology are available to you on your desktop or on your mobile phone. But selecting the article which is having good information for you to adapt is very challenging and difficult. In addition, you have to have 2 projects of research during your stay in KKESH. So when you want to plan your own research, the information of epidemiology will be useful to you. No research cycle is complete unless you finish publication of it, your findings. So manuscript writing also is an art, and knowledge of epidemiology will help you. When you are interacting with the staff of research department or your colleagues who have published, it will be easier for you if you know the basic terminology and information of epidemiology. If you want for your department something resources and you have to have evidence, decision makers are easy to convince, and that's why you can influence the decision maker for providing you required resources if you have the evidence and knowledge of epidemiology. You can be good teacher when you are interacting with the knowledge. And for everybody's academic growth, number of publication and international presentations are essential, and knowledge of epidemiology will help you in that. Recently, the mission of KKESH as well as research department is to improve the quality and quantity of research and publication. And we need all you people to be actively involved in this, whether it is a requirement for your thing or it is part and parcel of the incentive-based future programs which are coming for encouraging the research. We want you to have prospective studies to be taken, because many journals now, especially on the American subcontinent, are very hesitant in taking your manuscripts which are based on retrospective data. In the planning stage, if you have taken help of epidemiology and epidemiological input, your study becomes robust and publication becomes easy. This will help you in addressing the missing data, which is a big problem in a retrospective study. We have clinical coordinator course and we have staff. So when you are taking their help in data entry or for interacting with the patients, it will be easy and data entry will be smooth without much need of data cleaning. We have to have time-bound progress of our research, because that is the requirement for you to complete before 1 year or before you leave KKESH. And cycle has to be completed now by submission of your manuscript, and then one will get the completion certificate. Research is not the custodianship of only research department or few consultants. Everybody. And when I'm talking everybody, I'm talking about doctor, nurses, optometrists, and all supporting staff. One thing we have to remember is that when you do the research, do it in a scientific manner and be honest. Don't make the data on your own sitting on the table. What I am going to cover as an introduction to epidemiology is part and parcel of a 2-year course of Masters in Public Health. There are workshops which are going on internationally as well as online, that is evidence-based medicine. They are also talking about epidemiology. When you are talking about the WHO or other NGOs programs related to prevention of blindness and public health, they are also having the component of epidemiology integrated to it. And recently, through London School and Bill Melinda Gates Foundations, community ophthalmology training is going on for ophthalmologists as well as mid-level eye care professionals. They give MSc from London School of Tropical Medicine, and that also covers large portion of epidemiology. So when you want to do research, be it a planning stage, be in the field part when you are collecting the data, or after the data is collected, when the data is entered, analyzed, interpreted, and based on the results, when you are doing your PowerPoint presentation for a conference or writing the manuscript for a journal, or sometimes it is important to make a policy brief for changing the policy of patient care, then in all these steps, epidemiological knowledge will be applicable. So what is epidemiology? It is nothing else. It's a science blended with art to get the answers of how big is a health problem, what causes that health problem, when it is causing, what are the risk factors, and if we do the intervention or not do the intervention, how it is affecting the progression of a health ailment or disease. When this knowledge of epidemiology is applied to ophthalmology, it is called ophthalmic epidemiology. Different types of epidemiology sub-branches have come out now because the medicine is fastly progressing and diversifying. So diseases of infectious nature, when you are dealing with them, it is also an epidemiology of infectious disease. As far as ophthalmology is concerned, we are talking about conjunctivitis, congenital rubella syndrome, and amoeba manifestations. In chronic disease, which is the major part of our ophthalmic age-related diseases like cataract, glaucoma, dry eye syndrome, and age-related macular degeneration, patients live longer with this disease, and because of that, the burden of the disease is much, much higher, and their epidemiology is different than infectious disease. Newer genetic epidemiology has come up now for diseases like retinal dystrophies, and genetic is involved in most of our eye diseases. So you must know how to apply the epidemiology in genetic disease management. Screening is an important component in eye detection of early stages. We have newborn screening. Recently in Saudi Arabia, retinopathy of prematurity screening has taken place. Once upon a time, through school health and Ministry of Education, they were doing the school screening, vision screening of school children. Then opportunity screening, like diabetic patients are screened for diabetic retinopathy, and glaucoma patients are screened when they come with their any other eye problem to the ophthalmologist. So these are the screening related epidemiology, and there are certain norms which we will come later on. If we do public health intervention on a large scale, say eastern region or western region of Saudi Arabia, and compare the results with those who are still not yet implementing such type of preventive measures, then this also are type of epidemiological application to ophthalmic practices. Cost is a big factor in new generation technologies as well as equipments, both for diagnosis and management. And health-related cost effectiveness, if we calculate, that is also an important area of epidemiology which everybody is interested now. But we need to have good expert health economists in our team for doing such type of study. Impact assessment is very essential because we always think from the angle of providers, or we ophthalmologists, what we do and how it is affecting the vision or anatomical changes in the eye. But from client perspective, how it has changed their vision-related quality of life, health-related quality of life, and their satisfaction as far as ophthalmic services provided them. These are the studies and epidemiological part, which also is to be covered when we are talking about ophthalmic epidemiology. When we talk epidemiology in the research, there are few terminologies which are having equal names or meanings, both in public health as well as in clinical practice. What we call is risk factor or causes. In epidemiology, it is called exposure. What we call outcome or result in our clinical practice, like visual acuity at 6 months or 1 year, that is, in epidemiological term, outcome of any intervention or any treatment. Now, two terms in the morning I was talking to the clinical coordinators who are groomed in KKESH, the difference between the word prevalence and incidence. In most of the ophthalmic practices and diseases, we are more tuned to use the word prevalence because the disease is of chronic nature. It is lasting long. So if you are dealing with both new as well as old cases, we estimate the magnitude of the problem in the form of prevalence. But if there are acute conditions which get treated very fast, like allergic infective conjunctivitis, or certain conditions which has a very high risk of mortality, like myocardial infarction, in that there is no chronic condition. So we don't calculate prevalence in these cases. We present the data as incidence of this disease or ailment. When you are linking the outcome to the exposure or disease to its underlying causes, we use the word association in epidemiology. And same thing which in layman term we are using, it is linked to or it is related to. To understand the difference between prevalence and incidence, this is a good example of a village where there are many people. Some are every year developing cataract and they are added in the pool. The doctor is operating, so some of the cataract cases are going out. Some people die before the cataract surgery is done, so they also go out of the pool. So if you at any time look at the pool of people living in that village, they will have new cases as well as old cases with cataract. That is called prevalence. But if you look at how many every year new cataract cases are developing, that is incidence of cataract. So how we can have the correlation of incidence and prevalence? The simple formula for a chronic disease is prevalence is nothing else but incidence multiplied by the duration of that disease. So glaucoma, diabetic retinopathy, these are the conditions which will be at least 20 to 30 years, so their prevalence will be much, much higher compared to new cases detection in a hospital-based data. When we are doing the research, we have to remember that I will show you the pyramid, and as far as possible, we should try to get solid evidence. So different type of studies, observational studies, which are very popular among the clinicians, like case reporting, like case series, ecological studies, and cross-sectional studies or surveys. Well, analytical studies are time factor is involved, in which case control and cohort are the classic example of analytical study. But there are other studies in which a researcher is doing intervention, and they are clinical trial and public health intervention. We will go in detail to have a better explanation of that. And then newer studies or more solid evidence are collected from meta-analysis, invited reviews, and finally, preferred practice pattern. Some of the new studies which are really important according to me in setup like KKESH is newer equipments are coming, newer diagnostic tools are coming. We have to validate independently and not believe in what pharmaceutical industry is thirsting upon as the result of that equipment. Sometimes the studies done in other countries may not be applicable to our population. So this is the reason why validity study is an important thing the fellows and residents can take over here as soon as a new equipment or instrument comes in your domain. This is the pyramid everybody should try to climb. As we become experienced researcher, we have to go ladder up. Case report and opinions of our seniors or editorials are the poorest type of evidence. They are in the base of the pyramid. As we go up, clinical trials, cohort studies, case control studies, and surveys are the next step. But critically appraised primary research, meta-analysis, reviews are much, much higher evidence. And finally, preferred pattern practice is the gold standard by which you can alter your practice because it has been studied in depth by the expert and then recommendations are given. So, if you are writing a manuscript in the introduction, as far as possible, try to have your references from the top 3 or 4. This will make your introduction much sound. Do not take case series or case control studies when you are writing the references for your introduction. Case reporting, most of the journals are now refusing straight away. There are certain journals which are specifically for writing the case report, and if anybody is interested in the research department, we have the list of those journals. You can avail that. Unnecessary delay of publication of your hard work can be avoided if you don't submit it to the general ophthalmology journal because they don't take it. Unless it is really rare. It has its importance because first ophthalmologist who had case reported, and based on that the congenital rubella syndrome was invented and rubella vaccine had come out. So it has its own purpose to have the hypothesis development, but it has low evidence. These are some of the references which I have put, mostly are from KKESH. So these are the examples of case report and case series from KKESH. Ecological studies are group of two outcomes is compared of a variable, like we have different countries and their, say, GDP is available and the blindness rate is available. And if we plot them in the graph, we find that those who are poor countries with low GDP may have higher blindness rate. And then we can say that there is something to do with poverty. Blind people are more in poor countries. But that does not mean that all rich country people are not blind and all poor country there are no sighted people. In the sense, there is no one-to-one association. This is a group which we are trying to correlate, and that's why it gives a poor hypothesis rather than having any strong evidence. But ecological study has its own value for studies in which we are studying the effect of environment, pollution, because it is affecting group of people. So pollution related to Riyadh, Dammam and Jeddah, if you want to study, and its effect on dry eye syndrome, ecological study is the ideal one you can take. Cross-sectional study is very dear to public health people. It is a survey where a representative sample is examined for both exposure and outcome at one time. When we are collecting the information of exposure and outcome, we don't know which was first and which was after. So we cannot say that A caused B. So causal relationship we cannot establish. But we can say that there is something going on. When this is high, this is also high. Or when this is high, this is very low. So there is an association we can establish, but we cannot have causal or cause established. But it is a very good type of study for public health policy making. If we have blindness rate of different places of Saudi Arabia, the policymaker can decide, okay, let's focus on area which is having higher blindness rate first. Then we can think about giving the resources to the less prevalent areas. Now this is a very important slide for those who are interested to do good study in KKESH. Case control study and cohort study is to be clearly understood. This graph is showing you that when you have the information of disease first and group your patient into disease present and disease absent, and then look into their past to find out whether the cause is present or not, this is called case control study. So the golden rule is from disease to the cause, case control. It is very fast because all data is already available in track care. It is very good for rare disease because you can group disease present and disease absent in required number. At a time, you can study a number of factors which can influence disease presence. But we don't know when we are collecting the data whether the exposure was first or disease was first. When we examined, we know that disease is present and exposure is also present. So temporal relationship or which was first, chicken was first or egg was first, we can't establish in case control study. Compared to that, cohort study is much better because you are not relying on the data which is there in track care filled by somebody who has done the cut and paste at different follow-ups. Here in this, when you are planning the study, you can decide what variables you want to collect and you make a maximum effort to collect those variables. That's why the cohort study is more reliable compared to case control study. But in cohort study also there are shortcuts. Because the time factor is involved, when you are planning the study, if both exposure and outcome is not developed, and then you wait for exposure to come, and then after some time when the disease to come, then it is a prospective cohort study. The classic example is smokers among UK doctors. It is still going on after 70 years. The investigators have died, but some of the participants are still living. So such type of study is physically, practically not possible in institution like us, but the shortcut of that is you take the exposure information from past. When you are planning the study, there should not be any outcome. So when you are planning the study, cataract has developed, but you have not yet operated, and you don't know what will be the outcome after you operate the cataract in relation to visual outcome, diabetic macular edema. So in this case, this is called historical cohort study because part of the information you are collecting from past and you are waiting for the outcome to develop in future. And the third thing, which is a sort of a good name for case series, and that is retrospective cohort. Everything has happened in the past, but you are starting from exposure and coming out with the study outcome. So this is called historical cohort study, retrospective cohort study, and the ideal one is prospective cohort study. It's a powerful study, good for rare type of exposure or causes. Many outcomes can be studied at a time. We know exposure is first and outcome is second, so time relationship can be established, causal relationship can be established. Another good name of cohort study is clinical trial. The difference is in clinical trial, the investigator or research has control over who will get treatment A and who will get treatment B. While in cohort study, everybody will be randomly allocated, but we have no control over who will go in group 1 and group 2. So this is the main difference. Clinical trial is a sophisticated name of cohort study. Here, group A will get exposed and then you wait for the outcome to develop. And group B, you don't give that new exposure or new treatment, give conventional treatment and see what is the outcome in that group also and compare these two. The newer methodology where group A and group B in between are switched, or something which has happened that we are reaching the objective that, okay, the results of group A is fantastic compared to group B. So we all convert the patients into group A and continue as cohort. So these are some of the modifications and requirement of clinical trial. It's a powerful type of study, but sample size is very important in a clinical trial. Ethical issue must be attended because patient safety and patient's voluntarism is very essential and crucial. As I explained to you, there are methods of crossover technology in these studies. An independent body has to be established by ethical committee so that they can review and monitor the progress of such type of clinical trial and they can command when to stop. The stop can be if you have reached the objective or if there is a serious side effects of one arm. Prevention trials are usually done in public health. A large group of villages or area is given treatment or protection by vaccination or vitamin A supplementation, and certain eye disease prevalence is studied compared to the other group in villages where they are yet to be given or not given. When you are reading the references, journals, lot of meta-analysis studies will come. What is it? some studies which are done with a very small samples don't stand valid on its own, and the recommendation is further studies with a larger sample is recommended. So such type of small studies, results are collected, the data is reanalyzed, and then they come out with a conclusive evidence because now the sample size is very large, and this type of study are called meta-analysis. You require real skill and expertise and training for undertaking meta-analysis, and you must have an experienced biostatistician in your team for doing such type of exercise and publication. As I told you, validity study are really good studies, fast for fellows and residents. New test is compared versus gold standard or conventional treatment or tool which is there for investigation or diagnosis. It can be a cross-sectional type of study or a cohort study, but the parameters which are presented are sensitivity, specificity, positive predictive value and negative predictive value. Biostatistician will help you. But here you have to remember, one person is tested by two methods, the new method as well as old method. So this is a clear thing. If you have not done the two tests of same patient or same eye, you cannot do validity study. Now when you are doing study, three major evils are there which you have to be careful. Systematic error, bias, and confounder. When you are doing good planning of the study with the help of a team members, these are addressed and we have effect of these evils minimum in your study results. Systematic error means knowingly, by chance, because you have studied very small sample, error has come. So it could be true result, it can be a result which is influenced by small samples. This is called systematic error. So in the planning stage, if you have done good sample size calculation, this is having minimum effect. Bias means unintentional error which has come in your research. It can be mainly because of observer's bias or it can be selection bias. And this can be addressed by following normal standard pattern for selecting as well as doing the measurements. The last thing is potential confounder. That means the effect of some other factor also is there on your result. But you can study those factors. Like universal confounders are age, gender, area of residence, and level of education. If you are collecting this information, demographic information from your track care or anything, these potential confounders are automatically addressed at the time of analysis. Remember the difference between bias and confounder. Once bias is introduced, nothing can be done. So you have to be very careful in the planning stage so that the effect of bias is minimum in your study. But in case of confounders, if there are confounders, you can study the effect of confounder on your result, provided you have collected that information. If you have not collected that information, you cannot study the effect of confounder. So what to do? Take help of biostatistician in the planning stage for calculating sample size. As far as possible, wherever you get chance, randomize your allocation in group A, group B, or from the population or patient when you are selecting it, take some from this consultant, some under another consultant, some from the morning session, some from the evening session. So we are trying to do equal justice, and each participant or each patient will have equal chance of coming into research. When you are selecting the participants, we have to be very careful in ophthalmology. Should it be eye or should it be person? So for getting information which is related to demography, it is always by person. But we know that when we operate right eye, the result could be different compared to left eye. So when you are studying the outcome of your intervention, eye is the best unit. You use standard international definitions and document that in your method section, which definition you have used for each risk factor as well as each outcome you are going to study. These are all called quality assurance procedure. You will do pilot, you will do reverse translation of your data collection form. All these things, if you do, you are minimizing the effect of these three evils of systematic error, bias, and confounders. Every time measurement tools which we are using it, try to get calibrated periodically during your study so that the results of the first half and second half are uniform. I'm putting you one free downloadable software which is there from CDC Atlanta, which will help you as new beginner of researcher where biostatistical help is not that easy. And you want to do the basic analysis. This is the software by which you can do some basic analysis by using 2x2 table or by having the sample size calculation. It requires a long time for teaching this software, but once you are there, then the researcher is independent, and most of the time, except for advanced biostatistics, you don't have to really trouble the biostatistician. Randomization is an important thing, and for that, Microsoft Excel's function of randomization is easily available so that you can say that, okay, based on my randomization, patient number 1, 7, 13, and 19 will go in group A, while the remaining will go in group B. So in this way, this software is useful for randomizing your patient to go in to groups if you are doing a clinical trial. Now, another important dilemma which occurs is which study designed to adopt. I have a question, but which type of study I have to design, I have to do. For that, you better study the literature or the journals, what other people had done to answer the same question. Okay? Try to generate sound evidence better than the previous one, because if they have said that this was the problem, we did it in case control study, you better do it in cohort study. Okay? And always help of biostatistician and epidemiologist is there. Take help in the planning stage and things will be easy. But this is a general rule that if you are answering the question of how big is the problem, survey or cross-sectional is the ideal study design you have to adopt. If you are trying to find the cause, then case control is the better selection. Cross-sectional and case series are not preferred. But when you are studying the outcome or impact of an intervention or a progression of a disease, then randomized controlled trial and cohort are the better studies, but not cross-sectional or surveys. And lastly, if you want to generate hypothesis, because I did not find any article on this subject, and I want to start as the first article, then you can select any of these cases, but definitely not case report. So this is a standard method by which you can think or take help of epidemiologist if you forget about these things. Same thing BMJ has already put in their website. The questions of which are the best selected study designs. I had put it as a thing, but it's a repetition of previous slide. One thing which I have added this time anew, and that is screening, because more and more screening factors are coming into ophthalmic services, whether it is in the institution or whether it is in the part of prevention of blindness. We have newborn eye screening, we have ROP screening, we have amblyopia screening of preschool children. These are all recommended by international bodies. Whether they are happening in a particular country or not is a different thing. Vision screening for school children, maybe keratoconus screening for targeted to teenage children in countries where the prevalence of keratoconus is very high, like Saudi Arabia. Then diabetic retinopathy screening of registered diabetics, opportunity screening of glaucoma patients, active trachoma screening of 1 to 9-year-old children. This is mandatory for getting the certification from WHO to a country, and trachomatous trichiasis in adult population. So these are some of the ophthalmic screening. Very few are happening in Saudi Arabia, and you should take lead as part of your research or part of the system in prevention of blindness. But you have to remember that you should do the screening only in a condition where the prevalence is very high. If you detect the case early by going through screening or doing proactive work, it should make a difference in the life of that person. Then and then you do screening. If you are doing screening and telling him that you have cancer early and there is no treatment for that, you are increasing apprehension and burden in the family more rather than providing treatment in early stage. So some of the screening, because of this issue, have been discontinued. So in ophthalmology also, we have to remember genetic screening if we do, and if we at present do not have genetic engineering, we have counseling. So that is another option by which you can argue that genetic screening should be done. But still, genetic engineering is far on the horizon at present. So people are questioning the screening for genetic diseases. Intervention should be safe and cost effective. So screening should be done only on the condition where you can have prompt and low cost treatment. It should be acceptable to the people because it's not time consuming and troublesome. It should be valid, reproducible, safe, and cost effectiveness. So these are some of the screening, because in coming years, maybe with the medical student or maybe with you people, we will undertake some of the screenings in or outside KKESH as an outreach activity. So what we have learned that principle of epidemiology is applicable in all stages of ophthalmic research. We must adopt a better study design when we want to get good answer of the question which is raised. Less and less case report and case series we will have publication. More and more prospective studies we will undertake, which will have robust result and better acceptance rate in high index journal. And you cannot do research alone. We have to do it as a team, and then you will succeed. These are some of the websites which I want you to go. OpenAPI, Zotero, Epidata 3.1. These are very useful for early researchers, and once you get adapted to that, you can use it for your research as well as publication. One of my resident or fellow had taught me this thing which I was knowing till 2 years back, and that is use of Google Scholar for citation changes. So if you see this circled part, if you click that, different type of citations come. So you can select, copy and paste in your bibliography. A very simple thing. Suppose you have finalized and submitted the article to a journal. It rejected it. Now you want to change it because you want to submit it to another journal who is not taking Vancouver style, but they want to have AMA style. This is a very good tool by which you can change all the article bibliography very fast as required. The other option, these are the free downloadable softwares which are available, which is given by BMJ. I am well versed with the last one, and that is Zotero. So you also try to adopt one free software. EndNote is available at a cost, but other softwares are free. Mendeley and Zotero are widely applicable because it is free of cost. So download this to Zotero window and Zotero connector, and you can make your own library by downloading the articles both from PubMed as well as Google Scholar or other databases and make your own library. When you are when you have made your library, you can then insert in the Microsoft Word and you click the icon, number will come in the text, and automatically that article will be in the bibliography in the serial number. So Zotero is one good software which every researcher should learn if they want to have less work. What happens? A researcher or a fellow has written the manuscript, he has given the numbers, and they think that then when he is showing it to his mentor or consultant, he may change the order. Now, big work is there for changing all the bibliography. If you are using this type of software, this is not a problem. Automatical number changing takes place. So this is a tutorial for selecting a journal. I recommend you to go through it and focus specifically on ophthalmic journals and its impact factor. So when you are selecting a journal, whom you are targeting is very important. Are you targeting general ophthalmologist or your subspecialist? And second thing is your topic related to national issue or international issue? Based on that, then you have 2017 impact factor of ophthalmic journals. Get the list and decide which is the higher ranking journal and try to submit it. My habit is to go it for higher level. Even if it is rejected there, you will get some good comments by which you can improve, and most likely in the second level journal, it will be accepted in toto. So this is how you can have less rebouncing of your article if you have a trick of selecting the journal and aiming always higher. These are some of the database which is recommended: PubMed, Google Scholar, Scopus, Web of Science. So there are possibilities that I could not find the article in PubMed, but Google Scholar and other databases were having it. So to the best of my knowledge, this is probably the first publication in my... Most of the time we are wrong, because there are thinkers and creators who do simultaneous work. So be careful about using this word and try to see all this database if similar type of publication is done or not. So epidemiology is applicable in all stage. Knowledge will help, but work in a team. This is just a glimpse of epidemiology in research. You can improve your skill only if you apply it and take help of the software as well as experts who are always ready to help. Thank you. This is the first part of my presentation. I think we will wait for biostatistician to come probably so that we can take the biostatistical part as the second part. So if there are any questions related to epidemiology and research, I am happy to share my views about it. Yes?
Just thank you very much for the informative presentation of the research part. And you know, it's based application software, but we can work online and free.
See, working online is different thing and making your own library is different thing. Suppose I am a glaucoma subspecialist and I want to have today study primary congenital glaucoma. The articles which I have reviewed, collected PDF file and all this thing, I want to keep it for me for future second publication.
You can do it online.
Fine, no problem, but I found that $300 per year renewal of subscription is too much for me. If it is from institution, I have no problem.
Type of referencing, the mode reference, you can do it just one click and...
I agree with you. I'm not saying this thing. What I'm saying is I'm sharing my experience of using Zotero. That does not mean other softwares are inferior. Each one can have free selection of any of them, I have given all the different type of softwares which are available.
Just another idea. Thank you.
Yes.
Any other comments, questions? Yes. Can you give?
What is it?
These suggestions. She's asking about what is the meaning of these.
What I'm saying is that this is a 1-hour lecture of epidemiology. Usually, we did 2 days workshop in Qasim for budding researchers. So we cannot cover all the things, and we cannot have one-to-one interaction in 1-hour session. So suggestions are usually put that if you sufficient number of people, say 10 to 15, are interested, even fellows and residents, we can have a workshop taking their individual topic of their interest and go through the different stages of planning and execution of study.
That's a nice idea.
Yeah.
And what about the second line, the further studies?
Further studies means if you want to pursue your career and do MPH or MSc in community ophthalmology, then you can do it 2 ways, online, and second one is full-time course through sponsorship.
Thank you.
Okay.
So just one more question. Now, what about the time frame? So now we have residents and fellows who have a thesis and they would like to plan, as you mentioned, the type of the study, but in addition, the time. Can you differentiate between each study design? How much expected for each and how to guide them? Because they have, like, for instance, like deadlines to meet, and they always struggle. So can you, in your experience, can we just break it down into the IRB, first writing the proposal, then the IRB process, and then the data, and then the analysis, the last publication? Can you explain to them that how the process?
Okay, so what I suggest is whenever any researcher has idea and the mandatory requirement, come and talk to us. This will save a lot of your problem because we will explain you what type of literature review you are supposed to do. Then come back to us that, okay, we have crystallized this question for which this will be the objective. For this objective, this is the best study design. With this study design, what are the information we have to collect? So automatically you have thought about data collection form. Okay. Why we are insisting on IRB? 2 things. IRB helps you in systematic thinking. And second thing is we are looking after the ethical issue and patient safety. Okay? But systematic thinking has one advantage. If you have written your introduction and method of IRB form very judiciously, your half of the manuscript is ready because you can just cut and paste those introduction and methods in your manuscript. Only thing you have to do is change the tense. Instead of we will do in this way, now you have to write down we did in this way. So the half work of writing manuscript is over. The data you have collected, our coordinator will enter. We strongly recommend not to enter data on your own because we spend double time in cleaning the data if you have done on your own. Do small number of 5 cases, sit with the coordinator, match your data form with the computer format so that if there are any changes to be made in your form, we can do it in early stages. If you don't do it and after data is entered and you say, oh, we cannot analyze this variable because you have collected it wrongly. So be careful, work as a team.
Exactly. And then there is also one important tip that we can say. Since our IRB reports direct to the National Bioethics, we already sent to everybody as part of our weekly tips, the link to the National Bioethic. I would encourage every researcher to log in, register before it becomes like something like mandatory. That will give you a clue to what he was saying, how to enter the data, who's in charge, and everything. And this will answer all the ethical questions starting from writing the proposal until the submitting it. It has everything, and it's very simple. And also you have to answer the questions, and then they will give you the certificate. It's mandatory in every university, and for every residence, you know, or fellows everywhere in the world, the researchers who belongs to academic fields, to have a certificate. So this is an start. Go ahead and log in and do it. And once you know it, in future, if you work in any other places, like for Saudis, we know the national bioethic is going to be accepted. If you travel to any Gulf country or the state, then you will be forced to follow the same. But this is a start. This is a good start. Go ahead and take it, and you will understand it. And besides the workshops and everything, just to improve the knowledge. Yeah. Any other questions? Any comments? Okay. So I'll conclude that this is the end of this presentation. I would like to thank everybody for attending, and thank you, Dr. Rajiv, for informative lecture. Yeah.